a little unusual. A, I'm on time. B, I'm in a suit, so I'm a little uneasy here. I guess it was several weeks ago. The summer's been a bit of a blur. Sid and I spent about a week flying with the Air Force, and this was, we could talk for several hours about this. It was an unbelievable experience. We flew from Andrews to Ramstein, kind of got briefed, and then flew Ramstein to Balad, Balad to Kuwait, Kuwait back to Ramstein, and then picked up 30 or 40 relatively banged up kids in Landstuhl and flew them back to Andrews. It was really crystallized a huge amount for me. I spent 2 weeks in Landstuhl in January taking care of the kids, and so the opportunity to see the process kind of start to finish was really wonderful. I'll tell you, it's an unbelievably complicated process because the support structure that exists to get these kids from point A to point B to point C to point D is tremendous. The Air Force Base is a 50,000 person city, and they exist not solely, but a large portion of what they do is to support this air evacuation mission. We met, as you might guess, an incredible number of unbelievably committed people who are so on from the moment they walk in to the moment they walk out, and everybody is focused on being able to deliver this extraordinary level of care at 30,000 feet. The intensive care unit equipment is miniaturized, but we had essentially all of the bells and whistles we have upstairs in a room that is, you know, 2/3 the size of this on a stretcher, and we were able to provide that level of care at all levels. These kids go from the battlefield sometimes to receiving care in 4 different places for distances of, help me here, Sid, 20,000 miles, 15,000 miles, and get medical care in 4 different places and are in the United States in 3.5 days, which is an unbelievable set of logistics. It's you know, it's about 9.5 hours in the air from Ramstein here. It was about 6.5 or 7 Ramstein to Balad, another 6 back. Spent a lot of time in the air, and as you all know, we have this very, very close and hopefully getting closer relationship with the United States Air Force. I was really honored to be able to be a part of this mission. As I said, crystallized a huge number of questions for me, and we are going to use this information to continue to beef up the training here for the people that are coming through on their way over to the war. And I think what I'll do is let Sid kind of give you his perspective, and then we'll be available for a few minutes to take questions.
Hello, I'm Colonel Sid Brevard. I'm the director of Sea-Stars Baltimore. Sea-Stars Baltimore stands for the Center for Sustainment of Trauma and Readiness Skills. It's a cooperative agreement between the United States Air Force and the University of Maryland and the Shock Trauma Center to provide a platform for trauma refresher training for U.S. Air Force medics going to the war zone. When I say medics, I mean doctors, nurses, and medical technicians. They come here because on most Air Force bases, we really do not have a chance to take care of injuries from violence. So while they're here, they're exposed to 3 weeks of trauma care. that is hard to compare anywhere else in the United States. We invited Dr. Scalea to go with us on this mission to Balad Air Base, Iraq, to demonstrate to him what care the Air Force is providing to the warriors, and also how the care is performed. It's a complex operation, as Dr. Scalea said. It's not just taking care of a warrior who's been injured in a hospital. It's also what's involved in the transportation of him or her at each level of care. It begins when the injury occurs. When someone is shot or an IED blast occurs, a medic is usually the first one on the scene. They're immediately transported, usually by helicopter, to a trauma center in Iraq or Afghanistan. These trauma centers are staffed with surgeons who perform the initial stabilizing procedures, and usually within 12 to 24, 36 hours, they are moved again in the back of military aircraft to Landstuhl Regional Medical Center in Germany. These military aircraft are not just medical. They're U.S. transportation aircraft, and so they are equipped with specially modified medical equipment that is designed and built just to go in the back of these aircraft. Once they arrive in Germany, as Dr. Scalea saw, they are taken to either Ramstein Air Base or to Landstuhl, where they're reevaluated again, ensure they are stable, and then loaded back up the following day to fly the 9 hours across the Atlantic Ocean to the continental U.S. As we said, this whole process is very complicated. You have to make sure that each step of the way there is no degradation of the care we are providing. So what the Air Force hoped to gain from Dr. Scalea's experience is showing him we have several phases of care, not just in the hospital, but the transport out to the aircraft. As the aircraft is taking off, the aircraft at 30,000 feet, aircraft coming back for landing, and then the transport again. And now we can take his experience, our experience, and improve the training that our Air Force medics get before they go to the war zone. And that kind of summarizes what the whole mission was about. And I think we've accomplished it. We just need to take the lessons learned and make sure that our warriors receive the best possible care from this mission.
We have a couple of minutes. If people have questions, we're happy to address them, specifics or generalities.
How do you plan to improve the training? How do you plan to change based on your experience?
Well, I'm not sure yet, because we're sort of still comparing our opinions. The training is spans from physicians to nurses to technicians. It's really been much more about the in-hospital care and trying then to translate that to the entire experience. I'm going to guess that what we are going to do is spend more time or more concentration on the coordination of the care through all of the phases. I'm not sure that taking the in-hospital lessons are the best way to provide the care over the entire continuum of the times and the experiences that these people need in order to provide all of that care.
We also partner with the EMS system in the city of Baltimore, and we hope to strengthen that association and our medics who are riding along with the paramedics. And then as they ride along with the paramedics, actually bring the patients into shock trauma and hand them off to the Air Force doctors, nurses, and medics that are working in the shock trauma center, will simulate exactly the same situation that's occurring in the battlefield. So if we can practice that transition here, then we'll be able to provide better care in theater. And so that's just one facet. But there are other options we can work on also.
Is the process too complicated, or wounded soldiers being moved around too much? Is that causing problems?
I think absolutely not. I think it's exactly the opposite. I think what we have done is borrowed the concepts that were developed in civilian trauma centers in the late 1980s and early 1990s. The concept is called damage control, and it recognizes in the most severely injured patients, care is better provided not all at once, but in stages. And this is exactly the philosophy that the military is using, which is to do what you have to do as close, as close to the war as you need to be, but then transfer the patient to the next level and do this in a sequential way. The important thing is to be able to do that safely, and everything I saw says not only is it being done safely, it's being done superbly. And that's really being able to deliver care in unusual places, in this case in an airplane. But all of the tools that are necessary to take care of these injured military personnel exist in the back of that airplane. It was incredible to be able to see that work.
The survival rate for injured troops is the highest it's ever been in any conflict in the history of mankind from the last, since 2001.
And do Air Force medics care for wounded soldiers from all the branches of the military?
Yes.
And do they only do that in the air, or do they do that throughout the entire?
No, the Air Force mans the major trauma center at Bagram Air Base in Afghanistan, and also at Balad Air Base in Iraq. Air Force medics are deployed throughout the theater.
Is the Air Force the main branch for caring for trauma care, or do the other branches of the military have their own medics do the same thing?
The other branches have medics also. The Air Force is the major component at Bagram Air Base and at Balad, but the Army has lots of medics throughout both countries, and the Navy has personnel deployed also.
You talked about this relationship with the Air Force. Is that something that you're going to extend even further? I know he had mentioned the Air Force doctors and nurses witnessing what goes on here. Is there sort of a reciprocal relationship where you have also doctors from here that go out and experience the same thing that you did?
Great question, and the answer is that I believe that's going to be the next phase of our relationship. The Sea Stars program has existed for
Almost 7 years.
7 years. Each year, the relationship gets stronger. We now have not only very tight clinical training relationship, we have a very strong research relationship with the United States Air Force, and it is our hope that the next phase will be to link the educational missions as well, and that goes both ways. That will mean we would love to be able to link our resident and fellowship training with what the Air Force does in launch school and maybe further forward. It's going to require a huge amount of discussion and planning, but that would be my fervent hope that we can do that.
Could you describe some of your experiences caring for a patient midair, some of the complications and unexpected obstacles you ran into?
Well, I'm happy to say we didn't run into any unexpected obstacles on the flights that Sid and I were on. I think that it's a testament to both technology and commitment that the Air Force was able to equip the back, in this case, of a C-17 to be a flying hospital. And do we have, I'm not even sure which pictures we have here. You can see here that this starts out as an empty plane with just a bunch of racks on it. And then the ceiling opens up and the oxygen and the suction comes down, and the patients are transported with miniaturized intensive care unit equipment, and when you get done, it's a flying hospital. And the ability to bring resources that usually, or at least in the United States, require a huge amount of space to these kids that are flying back with, with obviously not that much space. I thought that the care that was provided was equal to that in the intensive care unit. It's as good as we delivered when I was in Germany at Landstuhl, and it's as good as the care we provide here. It's really very, very expert care, just with a very different look.
How does the care that you provided in Iraq, how is that different from what you need there? Are you improving the techniques or your patients?
I think that every time there's a military conflict, we learn a huge amount about injury. It's one of the times when all of us see a huge number of badly injured patients, and war is a terrible thing. We try to do what we can to learn from it, and I think that there are a number of big advances that we currently use here that have come out of our understanding of injury in the war. Use of a different way of resuscitating patients using less fluid, more blood and more plasma is a very clear example of how we do things differently than we did before the war. Use of topical hemostatic, the hemostatic bandages. There were none in 2000. I don't know how many there are now. It's hard to keep track because every 2 weeks a new company has a hemostatic bandage. These are, again, significant advances. We have looked at them in the research lab. We are now getting ready to bring those to clinical practice. Some things we thought were crazy, like foam that you just spray that stops bleeding, and it works. So how we will adopt this to our practice here, I think that's still undergoing discussion, but there are a significant number of advances, and we will take those advances. It's a different game. Our patients are different than the soldiers. The soldiers are cared for over a much longer period of time than our civilian trauma patients, but there's still a number of lessons that go across all of these various disciplines, and we ought to be able to be better, and I think we will be. Sure.
As we're beginning to expand troops in Afghanistan, are you going to be able to continue the same practices you're now doing in air over there, or is it going to differ?
It's the exact same process. The AirVac system works for both Iraq and Afghanistan. On the same day that we flew to Iraq, another aircraft flew to Afghanistan. We both made our mission into theater and back within about an hour or two of each other. And then right after we landed, the second aircraft landed, and the casualties from Afghanistan were taken to Landstuhl. So it's an ongoing process. It applies to both locations, and of course, several times a week, every week.
Thank you.
Thank you.